Asthma. Asthma is a chronic inflammatory disease of the airways that causes airway hyperresponsiveness, mucosal edema, and mucus production. This inflammation ultimately leads to recurrent episodes of asthma symptoms, cough, chest tightness, wheezing, and dyspnea. Asthma differs from the other obstructive lung diseases in that it is largely reversible either spontaneously or with treatment. Patients with asthma may experience symptom free periods alternating with acute exacerbations, which last from minutes to hours or days. Asthma can occur at any age and it is the most common chronic disease of childhood. Despite increased knowledge regarding the pathology of asthma and the development of better treatment medications and management plans, the death rate from asthma continues to increase. For most patients, it is a disruptive disease affecting school and work attendance, occupational choices, physical activity, and general quality of life. Allergy is the strongest predisposing factor of asthma. Chronic exposure to airway irritants or allergens also increases the risk for developing asthma. Common allergens can be seasonal, example grass, tree, and weed pollens, or perennial, 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 example mold, dust, roaches, or animal dander. Common triggers for asthma symptoms and exacerbations in patients with asthma include airway irritants, example air pollutants, cold, heat, weather changes, strong odors or perfumes, smoke, exercise, stress or emotional upsets, sinusitis with postnasal drip, medications, viral respiratory tract infections, and gastroesophageal reflux. Gastroesophageal reflux. Most people who have asthma are sensitive to a variety of triggers. The patient asthma condition will change depending upon the environment, activities, management practices, and other factors. Pathophysiology. The underlying pathology in asthma is reversible and diffuse airway inflammation. The inflammation leads to obstruction from the following: swelling of the membranes that line the airways, that is mucosal edema, reducing the airway diameter, contraction of the bronchial or smooth muscle that encircles the airways, bronchospasm, causing further narrowing, and increased mucus production, which diminishes airway size and may entirely plug the bronchi. The bronchial muscles and mucous glands enlarge, thick tenacious sputum is produced, and the alveoli hyperinflate. Some patients may have airway subbasement membrane fibrosis. This is called airway remodeling and occurs in response to chronic inflammation. The fibrotic changes in the airway lead to airway narrowing and potentially irreversible airflow limitation. Cells that play a key role in the inflammation of asthma are mast cells, neutrophils and eosinophils, and lymphocytes. Mast cells, when activated, release several chemicals called mediators. These chemicals, which include histamine, bradykinin, prostaglandins, and leukotrienes. Leukotrienes, leukotrienes, perpetuate the inflammatory response, causing increased blood flow, vasoconstriction, fluid leak from the vasculature, attraction of white blood cells to the area, and bronchoconstriction. Regulation of these chemicals is the aim of the current research regarding pharmacologic therapy for asthma. Further, alpha and beta adrenergic receptors of the sympathetic nervous system are located in the bronchi. When the alpha adrenergic receptors are stimulated, bronchoconstriction occurs. When the beta adrenergic receptors are stimulated, bronchodilation results. The balance between alpha and beta receptors is controlled primarily by cyclic adenosine monophosphate. Small c, capital A, capital M, capital P. That is the symbol for this. Cyclic adenosine monophosphate. Alpha adrenergic receptor stimulation results in decrease in CAMP, which leads to an increase in chemical mediators released by the mast cells and bronchoconstriction. Beta receptor stimulation results in the increased level of CAMP, that is cyclic adenosine monophosphate, which inhibits the release of chemical mediators and causes bronchodilation. Clinical manifestations. The three most common symptoms of asthma are cough, dyspnea and wheezing. In some instances, cough may be the only symptom. Asthma attacks often occur at night or early in the morning, possibly due to circadian variations that influence airway receptor thresholds. An asthma exacerbation may begin abruptly, but most frequently is preceded by increasing symptoms over the previous few days. There is cough with or without mucus production. At times, the mucus is so tightly wedged in the narrowed airway that the patient cannot cough it up. There may be a generalized wheezing, the sound of airflow through a narrowed airways, first on expiration and then possibly during inspiration as well. Generalized chest tightness and dyspnea occur. Expiration requires effort and becomes prolonged. As the exacerbation progresses, diaphoresis, tachycardia and a widened pulse pressure may occur along with hypoxemia and central cyanosis. This is a late sign of poor oxygenation. Although life-threatening and severe hypoxemia can occur in asthma, it is relatively uncommon. The hypoxemia is secondary to a ventilation perfusion mismatch and readily responds to supplemental oxygenation. Symptoms of exercise-induced asthma include maximal symptoms during exercise, absence of nocturnal symptoms, and sometimes only a description of a choking sensation during exercise. Asthma is categorized according to symptoms and objective measures of airflow obstruction. Assessment and diagnostic findings. A complete family, environmental and occupational history is essential to establish the diagnosis. The clinician must determine that periodic symptoms of airflow obstruction are present, airflow is at least partially reversible, and other etiologies have been excluded. A positive family history and environmental factors including seasonal changes, high pollen counts, mold, climate changes, particularly cold air and air pollution, are primarily associated with asthma. In addition, asthma is associated with a variety of occupation-related chemicals and compounds, including metal salts, wood and vegetable dust, medications, example aspirin, antibiotics, piperacin, cimetidine, industrial chemicals and plastics, biologic enzymes, that is laundry detergents, animal and insect dust, sera and secretions. Comorbid conditions that may be accompany asthma include gastroesophageal reflux, drug-induced asthma and allergic bronchopulmonary aspergillosis. Other possible allergic reactions that may be accompany asthma include eczema, rashes and temporary edema. During acute episodes, sputum and blood test may disclose eosinophilia, elevated levels of eosinophils. Serum levels of immunoglobulin E may be elevated if allergy is present. Arterial blood gas analysis and pulse oximetry level reveal the hypoxemia during acute attacks. Initially, hypocapnia and respiratory alkalosis are present. As the condition worsens, the patient becomes more fatigued. The PaCO2 may rise. A normal PaCO2 value may be a signal of impending respiratory failure because CO2 is 20 times more diffusible than oxygen. It is rare of PaCO2 to be normal or elevated in a person who is breathing very rapidly. During an exacerbation, the FEV1 and the FVC are markedly decreased but improve with bronchodilator administration. Pulmonary function is usually normal between exacerbations. Prevention. Patient with recurrent asthma should undergo tests to identify the substances that precipitate the symptoms. Possible causes are dust mites, roaches, certain types of cloth, pets, horses, detergents, soaps, certain foods, molds and pollens. If the attacks are seasonal, pollens can be strongly suspected. The patient is instructed to avoid the causative agents whenever possible. Complications of asthma may include status asthmaticus, respiratory failure, pneumonia, and atelectasis. Airway obstruction, particularly during acute asthmatic episodes, often results in hypoxemia, requiring the administration of oxygen and monitoring of the pulse oximetry and arterial blood gases. Fluids are administered because people with asthma are frequently dehydrated from diaphoresis and insensible fluid loss with hyperventilation. Medical management. Pharmacological therapy. Two general classes of asthma medications are long-acting medications to achieve and maintain control of persistent asthma and quick relief medication for immediate treatment of asthma symptoms and exacerbations. Long-acting control medications, corticosteroids, are the most potent and effective anti-inflammatory medications currently available. Anti-inflammatory agents that are used more commonly in children. They are effective on a prophylactic basis to prevent exercise-induced asthma or in unavoidable exposure to known triggers. These medications are contraindicated in acute asthma exacerbations. Long-acting beta-adrenergic agonists are used with anti-inflammatory medications to control asthma symptoms, particularly those that occur during the night. Methylxanthines are mild to moderate bronchodilators, usually used in addition to inhaled corticosteroids, mainly for relief of nighttime asthma symptoms. Combination products are also available, that is albuterol and ipratropium. Quick relief medications, short-acting beta-adrenergic agonists are the medications of choice for relieving acute symptoms and preventing exercise-induced asthma. They have a rapid onset of action. Anticholinergics may bring added benefit in severe exacerbation, but they are used more frequently in COPD patients. The list of medications, medication class, long-acting control medications and quick relief medications. First one is corticosteroids, mast cell stabilizers, long-acting beta-adrenergic agents, that is salmeterol, albuterol, xanthine derivatives, aminophylline, theophylline, leukotriene modifiers and combination products, albuterol sulfate, ipratropium, bromide. Quick relief medications are short-acting beta-adrenergic agents, albuterol, pirbuterol, levalbuterol and bitorolitol. Anticholinergics, ipratropium, bromide. Management of asthma exacerbation. Asthma exacerbations are best managed by early treatment and educating the patient. Quick acting and beta-adrenergic medications are first used for prompt relief of airflow obstruction. Systemic corticosteroids may be necessary to decrease airway inflammation in patients who fail to respond to inhaled beta-adrenergic medications. In some patients, oxygen supplementation may be required to relieve hypoxemia associated with moderate to severe exacerbation. Also, response to treatment may be monitored by serial measurements of lung function. Patient self-management and early recognition of problems lead to more efficient communication with healthcare providers regarding an asthma exacerbation. Peak flow monitoring. Peak flow monitors measures the highest airflow during the forced expiration. Daily peak flow monitoring is recommended for all patients with moderate or severe asthma because it helps measures asthma severity and when added to symptom monitoring indicates the current degree of asthma control. The patient is instructed in a proper technique, particularly to give maximal effort. The personal best is determined after monitoring peak flows for 2 to 3 weeks after receiving optimal asthma therapy. The green, that is 80 to 100%, yellow 60 to 80%, and red less than 60% zones are determined and specific actions are delineated for each zone, enabling the patient to monitor and manipulate his or her own therapy after careful instruction. This reinforces compliance, independence, and self-efficacy. Thank you.